All right. Thank you for joining me once again. This is lecture number 6 out of 7 that I have prepared on basic ventilator management. This one is a real fun one. I really enjoyed making this one. This one, we will be discussing the basic analysis of ventilator waveforms and loops. Now, this is a topic that I used to find very daunting, very frustrating, on account of the fact it just seems like it's so much to remember and it's so many things to pay attention to. And the waveforms and loops can represent so many different things. I always used to feel like I couldn't possibly remember it all. The good news is, when you really think about it, it's just a graph. It's nothing to be afraid of, nothing to be worried about. As with any basic two-dimensional graph, really, all that we're doing with any of these waveforms or loops is we are analyzing the relationship between X and Y. That's it. We shouldn't really make it that much more complicated in our mind. Just as on this graph we have here on the side here, which we have our X-axis on the bottom, which demonstrates a person's age over time, and on the Y-axis we have knowledge about dinosaurs, showing the relationship between a person's typical knowledge about dinosaurs as they progress with ages. And we can see it's a fairly linear decrease downward. And I thought that that was pretty funny. But it just shows that really we're not really analyzing anything that's more complicated than this. In trying to learn about waveforms before, I've kind of fallen into a trap that makes it more difficult for me. I tried to memorize visually what all the different loops and waveforms might look and under different circumstances, and it's just impossible for me to grasp. Too impossible for my mind to hang on to all this stuff. So I find that it's easier that rather than memorizing all of the possible shapes and variations, it's easier to just take it one waveform at a time and focus on that relationship between X and Y. I like to think of it as instead of memorizing a shape, I'm writing a wave, just comparing X and Y. And the really good news is that in all of our ventilator waveforms and loops, the X-axis remains constant. It's always the same thing. It represents time. X equals time. So I'm going to go over our different scalars that we will see on the ventilator and go over just its component parts and just information we can gather from them. So we're going to start with our pressure waveform. This is kind of a theoretical idea of what a normal pressure waveform should look like. Most of these waveforms are also in volume control just because that's what we're working in most of the time. In volume control, we see something like this, a gradual increase in pressure over time until we reach our peak pressure, and then a rapid deceleration back to the baseline. Now, this waveform here obviously does not show the presence of any peep. Usually we're going to see some peep like in this very crude drawing I have down here below. Pardon those crude drawings. In my reference materials, it was hard for me to find all of the waveforms that I wanted to demonstrate all the things I wanted to demonstrate. So there's some crude drawings in here as well. So on this waveform, we have peep represented. And the peep is important. If our peep is optimal, this also represents our FRC, our functional recruited alveoli. Peak pressure is represented up here. And assuming a inspiratory hold maneuver is taking place, we have this, which represents our plateau pressure, and then a gradual descent to our peep. All of this space under this waveform here represents our mean airway pressure. Our mean airway pressure is the average of everything that's happening underneath this waveform. And this, when we are looking at oxygenation and such, this is technically more important to look at than PEEP. We tend to think of increasing PEEP as a way of increasing a patient's oxygenation, but that really only happens as much as PEEP contributes to this overall picture of mean airway pressure. Taking a look at the components of the breath cycle from a pressure waveform, again, just for simplicity's sake, I haven't represented PEEP here. So we see a dip below the baseline here indicates a patient trigger Usually, if the ventilator were using pressure trigger, this segment represents our inspiratory flow. This little cliff here represents the cycling phase of the breath, and then our fairly linear expiration back down to baseline. Just taking a look at some abnormal things we might see in a pressure waveform. Let's just take a closer look at this waveform here. So we have our gradual rise in pressure here, a drop here. This marks our plateau pressure here, our drop back down to baseline. But we see this little dip below the baseline here that isn't followed by a subsequent waveform, at least not immediately. What this usually will indicate is a failed trigger. The patient is attempting to take a breath, but is not receiving one. In which case, if we're seeing this kind of thing, we need to address our sensitivity settings. This waveform here, we see a slow rise in pressure over time, but then there is a sudden negative deflection here, where the patient is clearly trying to take a breath on top of what we're giving them, increase in pressure again, and our normal deceleration here. This marks the presence of flow hunger. In other words, the patient's diaphragm is dropping faster than what the ventilator can deliver on the current settings. When this happens, you might also see high peak inspiratory pressures because of the asynchronous situation. So basically, you have the patient's diaphragm, in this case, trying to rebound while the vent is still trying to give the breath, and this is going to give us the presence of peak pressures that we don't want to see. So in this situation, the ideal thing to do is to increase the set flow to meet the patient's demand. Okay, so here are some diagrams that show how our pressure waveforms might change as we experience resistance and compliance changes. Over here, as we can see from this waveform to the next, we've got this little delta here between our peak and plateau. But what we have on this waveform, there is a larger delta between our peak and plateau here. This is indicative of increased airway resistance, as opposed to this waveform here, where we see a similar delta on this first waveform, but as you experience compliance changes, the waveform may reach a different size, but that delta remains pretty much the same. We have a 5 centimeter water pressure delta between each of these waveforms here. So that is a very easy way that we can use to quickly distinguish between changes in compliance versus changes in resistance. Taking a look now at the flow waveform. What we see here in a normal waveform in volume ventilation. So here we have a square waveform where we have our rapid increase in inspiratory flow until it reaches a constant level, until cycling occurs. And we have our passive exhalation. So the flow waveform and volume control is always going to be fixed. The inspiratory portion is always going to be on the top, and the expiratory portion is always going to be on the bottom. What we should always expect to see is that on the expiratory portion, we should experience a complete return to baseline before the next breath is initiated. On this graphic here, I've hand-drawn just some of the different inspiratory flow patterns that we'll see depending on the ventilator that we're using. As I said, this is our square inspiratory flow pattern. A decelerating waveform, we expect to see a rapid increase in flow, followed by decelerating flow before cycling occurs. And on ventilators that will allow us to emulate sinusoidal inspiratory flow patterns, you're going to see a gradual increase in flow until you reach peak flow, and then a gradual decrease in inspiratory flow until cycling occurs. So looking again at the components of the breath cycle here from the flow waveform perspective, here we have our trigger. This top portion represents our inspiration. Our cycling occurs here, and our expiration occurs here. Now, it's important to note that the point in the waveform is different depending on whether we're looking at a square inspiratory flow pattern or a decelerating or sinusoidal inspiratory flow pattern. Because where we see cycling occurring at the top right corner of the square waveform here, in the decelerating inspiratory flow pattern, we have a gradual decrease in inspiratory flow before we sort of reach baseline here, and then cycling will occur. And we observe a similar thing with sinusoidal inspiratory flow. Some abnormal things we might see. We take a look at this waveform here. On the expiratory side, we observe an incomplete return to baseline here. And this is indicative of air trapping. In these cases, the patient may need to have their flow increased. Even if they don't appear flow hungry, they may need a decreased tidal volume, decreased respiratory rate so that they can have more time for exhalation, or they may need their PEEP increased. In the case if they are air trapping because they are emphysematic, this can allow for trapped gases to equilibrate with the rest of the airways to allow for a more complete exhalation. Taking a look now at our volume waveform. This is what a typical volume waveform will look like in volume control. We should see a pretty linear increase in volume, followed by a slightly less linear but passive decrease to baseline. Again, the volume should start at 0, rise to the set volume, and then fall back to 0. And I've marked on my hand-drawn waveform, this is where you can manually measure your tidal volume. The components of the breath cycle from the volume waveform standpoint, we see here at the beginning is our trigger. We have a linear phase of inspiratory flow. Cycling occurs at the peak, and then we have the expiratory phase. And again, we should see this return all the way to baseline. Some abnormal things we might see. In this waveform here, we have our gradual increase to the peak, a gradual deceleration here, but then there's no return to baseline here. And again, this is indicative of either air trapping or leak. And the way that we differentiate between the two is we can refer to the flow waveform. If the expiratory flow also does not return to 0, then air trapping is clearly the issue. If the flow waveform is normal, then we can clearly identify that leakage is the issue. Something else we might see. This is across all of our different waveforms here. Let's take a look at this pressure waveform. We have our gradual rise here, but then we have this brief negative inflection here, and then another quick rise in pressure before there's a quick drop back down to baseline, or sometimes not to baseline. On the flow waveform, in conjunction with this, we will see a rapid increase in flow. So this would be in a decelerating flow waveform. But then before it has a chance to reach baseline, there's a very quick negative deflection below baseline, and then another breath is quickly administered here. This is sort of outside of the normal succession from breath to breath. We have our volume waveform, which quickly rises, then quickly drops to 0, often before reaching the set volume. And this is immediately followed by another waveform, which may actually drop below 0 on exhalation. And what you're having here is breath stacking. And on that volume waveform, which you might measure down here on this expiratory side as it goes below baseline here, is you're going to see exhaled tidal volume that is about equal to twice of your set volume. This shows us that the tidal volume that the patient is receiving is not nearly large enough to reach the patient demand. We have here a representation of air leak and auto-cycling. We can see here that on the pressure scalar here, there is an inability to maintain PEEP there is the presence of supported breaths without an obvious trigger. I'm not seeing any obvious triggers here on the flow waveform or on the pressure waveform, okay? And we have these moments on the volume waveform where we're not returning to baseline. Here we have a representation of air trapping from small airway collapse. So these scalars are assuming the presence of a manual expiratory hold. In this case, the destruction of normal airway structure will create scar tissue that collapses easily, resulting in an early airway closure during exhalation. So this effect can be observed in measured PEEP values above set PEEP during the maneuver. So we have what clearly is our set PEEP at about 5, and then we have the PEEP rising above the set PEEP to about 7 during the maneuver. This effect can be remedied by increasing PEEP to allow the trapped gases to equilibrate, allowing a more complete exhalation. Here we have a representation of dysynchrony from inadequate flow. We have the initial pressure scalar shows a downward scoop curve during the inspiratory phase. And then the second scalar shows improvement following an increase in peak flow rate. Here we have a representation of dysynchrony resulting from inappropriate trigger sensitivity. So we could take a look at our pressure scalar here. This indicates negative deflections without subsequent delivery of breaths. And we can also see comparable bumps on the volume waveform and on our flow waveform as well. Here's a representation of dysynchrony from patient vent rate mismatch. We could take a look at the abnormal patterns on both the inspiratory and expiratory phases of the breaths. We're seeing these little divots here and here and here and here, as well as on the pressure waveform. Sudden drops in pressure here, 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 but there's no particular rhyme or reason to when these are happening. They're not recurring at the same place on the waveform. They change from breath to breath. And we can say conclusively that this is due to patient vent rate mismatch as opposed to flow hunger, because in flow hunger, we may see similar sort of aberrances, but they will tend to occur in the same place. Here we have a representation of excessive eye time. Looking at our flow waveform here, we can see that there is an obvious gap in between end inspiratory flow and the start of exhalation. This is a situation that's typically uncomfortable for the patient, and settings should be adjusted to try to do away with that. We can also see here on the pressure waveform that at the top here, we see this brief deflection upward above our what would otherwise be our normal peak pressure there, and this is indicative of active exhalation against a closed expiratory valve. Here we have a representation of excessive inspiratory pressure. So there's a spike at the beginning of each pressure waveform that indicates that there is the presence of flow and pressure being delivered that doesn't necessarily result in an increase in tidal volume. Okay, now we see here a representation of obstruction. We can take a look at a comparison between these two waveforms right here. This is a more normal waveform that we should expect to see. And waveform B here, we see on the expiratory side of things that expiratory flow seems to be prolonged when compared to the initial waveform there. We can also observe here on the volume waveform that the time for volume emptying seems to be extended when compared to the initial waveform there. And this is due to expiratory resistance. All right, now time to move on to our loops. We're going to start looking at our flow volume loop, And here's the two common ways that you will see it shown. The one here on the left is typically the pattern that you will see in your PFT type scenarios, but on most vents that I've seen, it's represented here. On top here, we have the expiratory side here, where this peak here marks our peak expiratory flow rate. Our start of inhalation is here. We have our inspiratory side here, and this part marks our start of exhalation here. Similarly, on this side here, the start of inhalation begins on the other side. On both of these waveforms, the progression of the loop will move in a clockwise direction. We have our inspiratory side, where we'll have our increase in flow over time, and then a decrease in inspiratory flow over time. And then our expiratory phase proceeds along this particular pattern here. Some abnormal findings we may see. Here is a representation of a sort of sawtooth pattern on the expiratory side of here. And we can see this type of thing on either the expiratory or inspiratory side of the loop here. And this can usually indicate one of three things. There is either excessive secretions that the patient has, and they need to be suctioned, or there is some sort of liquid in the breathing circuit, and you can determine which side that's coming from depending on whether or not you're seeing this pattern on the inspiratory or expiratory side of the loop. Or this could also indicate turbulent flow from bronchospasm. Some other things we could expect to see. We can take a look at this waveform here, depending on which one you want to look at here. We have our inspiratory phase looks fine, but then expiratory flow, there seems to be a severe restriction of flow. This seems to be very, very depressed, and this is indicative of obstruction. Take a look at this waveform here. We see a much smaller loop in general with a very depressed inspiratory side. So this represents smaller long volumes and reduced inspiratory flow, and this is a sign of restriction. All right, taking a look now at our pressure volume loop. I've got a couple of different representations to show different components of the breath cycle, and this is assuming a positive pressure breath. Over time, we see a gradual increase in pressure, and then at a certain point, that relationship between rise in pressure and rise in volume becomes linear up until this point right here. This point also represents our tidal dynamic compliance. And also looking at it from the volume side of things here, this represents our tidal volume. And then we see a gradual decrease in pressure and then a corresponding decrease in volume back to the baseline. And we should see this come back to the baseline here. All right, now this is a little bit more abnormal type of pressure volume loop that we might see. The initial abnormal thing that sticks out to me is this sort of fishtail appearance. And this usually indicates that the patient has some increased work of breathing or difficulty triggering a breath, in which it is important to address any sensitivity or flow hunger issues. Taking a deeper look at our abnormal pressure volume loop here. As is typical, we can see here that over time, we have gains in pressure without much of a corresponding gain in volume until we reach a certain point where our alveoli pop open and the pressure results in greater gains in volume. Between here, what is our lower inflection point and our upper inflection point, the pressure-volume relationship should be pretty much linear, meaning that for every X amount of pressure that we gain, we should see a Y amount of gain in volume. The lower inflection point is an indicator of optimal PEEP, and the upper inflection point gives us a guideline of where our pressures should not be exceeding. And if we keep those in between those parameters here, we should find ourselves relatively free of the types of shear stresses that can cause cyclic atelectrauma. At this point here, we see this sort of bird beak appearance. If we see that, that indicates that we have violated the upper inflection point. After this point, we see a widened expiratory phase here, meaning that we are experiencing changes in pressure without that much decrease in volume. This could indicate some sort of expiratory resistance. At this point here, where we have this sudden drop back to the baseline here, this marks our critical closing point, and this is an indicator of our minimal PEEP. We can look at the pressure volume loop here to identify and understand changes in static compliance that our patients may experience. On a normal patient, you should expect to see a pressure volume loop that kind of goes right up the middle there. But if the waveform dips down to the lower side here, it usually indicates a decrease in static compliance. An upward deflection will indicate an increase in static compliance. We can see this when we have issues like pleural effusion, pneumonia, atelectasis, ARDS, pulmonary edema, and such. And this upward deflection is something that we should expect to see in our emphysematic patients. Now, it's important to keep track of this because over time, as a patient's static compliance improves, we should see this deflect more and more in the proper direction. Okay, when we see this here, we see some issues. In the center here, we have a fairly typical pressure volume loop here, but we're looking at this other loop here. We see substantial gains in pressure without substantial gains in volume up into a certain point where we have a rapid rise. And then on the other side, we see substantial decreases in pressure before we see significant decreases in volume, indicating expiratory resistance on this side and inspiratory resistance on this side. Loss of volume can easily be identified. On our pressure volume curve, we see a normal rise, normal expiration, and to a point where we see the loop not returning to its starting point. On our flow volume loop, we see a typical inspiration here, and then on exhalation, we see that the volume falls short of the starting point, indicating we have some sort of leak. On this particular loop, we have a normal inspiratory side, and on the expiratory side, we see our gradual deceleration and no return to baseline there, indicating air trapping. This diagram here shows how volume-targeted breaths and pressure-targeted breaths will appear on the pressure-volume loop. In the black here is our normal loop in volume-targeted breaths, and the green one shows what they will look like in pressure-targeted breaths. In pressure-targeted breaths, you're going to see a pretty much linear increase in pressure over time up until we reach end inspiration here. So I'm going to go over a few case studies so that we can put everything that we've learned together and try to really get into the nitty-gritty of what's happening on these particular scalars and loops. So case one, we have a 4-month-old male, previously treated for respiratory distress syndrome and BPD for 3 months as a result of premature birth at 28 weeks gestation. After being at home for 1 month, he presents to the ED with what the mother describes as blue spells, coughing, gagging, large amounts of clear white nasal secretions, poor feeding, and periodic apnea. After arriving at the ED, he stops breathing and is intubated with a 4O ET tube. He's transferred to the PICU and placed on a vent on PCAC with a PIP of 18, PEEP of 4, respiratory rate of 24, and FiO2 of 40%. Subsequent chest X-ray shows perihilar infiltrates and right upper lobe atelectasis. We take a look at this patient's scalars, and we see something that looks a little abnormal. Taking it one waveform at a time, we can see our flow waveform has a rapid rise to the peak here. We have a decelerating inspiratory waveform here, indicating that we are indeed in pressure control. We have, in our expiratory phase, we see these disturbances in the flow waveform, where they're going up and down here. And then inspiration appears normal, and then expiration begins, and then we begin to see these sort of disturbances repeating themselves. We can see a very similar pattern in the pressure waveform, as well as similar disturbances in the volume waveform. We can clearly see that these disturbances are only happening on the expiratory side. Let's ask ourselves, so that's what's abnormal about the scalars for the patient, and what intervention should be performed. To me, this is indicative that the patient has a lot of secretions and they need to be suctioned. Case number 2. A 40-year-old female, status post-motor vehicle accident. After 3 days in the ICU, she was being ventilated with volume control SIMV with a tidal volume of 750, a PEEP of 7, and a respiratory rate of 16. Taking a look at our pressure volume loop, we see some abnormal things. Just taking it one step at a time, I see, starting here, well, looking back, the set PEEP was 7, and our pressure loop begins at 10. So that tells me that we might have some auto PEEP or something present there. There is our typical increase in pressure. We have our lower inflection point rising up to our upper inflection point. We're not seeing any violation of that upper inflection point. But upon exhalation, we're seeing some disturbances and a brief increase in volume and pressure, followed by our return to our baseline of 10, which shouldn't be 10 because our set PEEP is 7. This, to me, is very clearly showing that we're having some sort of patient-vent synchrony issue. Continuing with this case, so in an attempt to better synchronize the ventilator to the patient without sedation, the mode was changed to pressure support, and this is what our loop looks like after the change. So let's take a look at how the new vent changes have affected the patient-vent synchrony here. I'm not seeing any more of those weird aberrances here. I'm seeing what we should expect to see from a pressure mode. We have a fairly linear increase in pressure up to the peak here. I'm also seeing that our auto PEEP has resolved itself because our baseline here is about 7, again, where we have our PEEP set. So case number 3, and let's assume that this is a patient you know nothing about. You've been called to the ICU unexpectedly to cover for a therapist who's out of commission, and you have no idea anything about this patient, but you go to assess them, and you see loops and waveforms that look like this. Okay, let's take a look at what might be abnormal about this. So we have our pressure volume curve here, and we're seeing a very wide waveform. We're seeing massive gains in pressure before there's any significant gain in volume, and we're seeing a similar thing on the expiratory side. Massive decrease in pressure before there's any significant decrease in volume. This, as we talked about before, indicates increased airway resistance. Looking at our flow volume loop, we're seeing fairly normal inspiratory phase here, but we're seeing a restriction of expiratory flow here, or a limitation of expiratory flow rather, indicating that there's some obstruction present. Looking at our pressure waveform, we see our normal rise to the peak pressure, but there's a fairly significant delta between our peak and plateau here. also confirming the presence of increased airway resistance. And as we look at the flow waveform here, we see a square flow waveform where we have a rapid rise in inspiratory flow, a steadying of inspiratory flow before cycling, and then our expiratory waveform does not return to baseline, indicating air trapping. So what does this all point to? This all points to severe obstruction and increased air resistance. This patient is probably status asthmaticus in a very rough spot, and they probably need real heavy bronchodilators at this point. Okay, now we're going to play a little game called Name That Mode. And we're going to take a look at these waveforms. We're going to analyze it step by step to see if we can identify what the mode is. Right here, we're going to take it one waveform at a time, taking a look at our flow waveform. First of all, first thing I notice is that the flow waveform is square. At least this flow waveform is square. This one is not. This one is, these two are decelerating. Okay, that tells me right off the bat that these are machine-given breaths and these are spontaneous breaths. Taking a look at our waveform, we see a similar pattern. We have these waveforms that seem to be giving us larger volumes, and these waveforms corresponding with these flow waveforms show breaths that are present, but volumes that are not as significant. Taking a look at the pressure waveform, we see our linear increase in pressure here. We see our exhalation here, but before the next subsequent breaths here, we see negative deflections in pressure, indicating patient effort. And what does this all point to? This is a volume control SIMV with spontaneous pressure support breaths. All right, next mode. Okay, so what we have here is a look at our flow waveform. It is a decelerating flow waveform. Everything looks normal there, okay. Our volume waveform shows our very typical increase and decrease back to baseline here. And the pressure waveform, thing that I see that sticks out is that this is a square pressure waveform. So what do we have when we have a decelerating inspiratory flow pattern and a square pressure waveform? That can only be pressure control, assist control. So the next mode here, we have an inspiratory flow pattern that is square. It looks pretty typical, pretty normal. The waveforms look very regular from breath to breath. I'm not seeing any significant deflection in flow at the instigation of each breath here. And I'm not seeing that manifest on the pressure waveform either. Given all those things together, the only thing that this could be is CMV, true CMV. All right. This next mode, we have, again, we have a square inspiratory flow pattern. Although I will say that these complexes do seem narrower than what we saw on the CMV pattern. As in, we have a shorter respiratory cycle here. The volume waveform, there's nothing really interesting there. But we can see here on the pressure waveform, we have these little negative deflections at the beginning of each breath, indicating that these are assist breaths. So the only thing that this could be is volume control, assist control. All right, I hope you enjoyed this presentation. It was fun for me to put together. Remember, vent waveforms, they shouldn't be intimidating at all. Really all we're doing is we're comparing X and Y and really taking the time to ride that wave and analyze the relationship between the two variables. The The x-axis always represents time. That makes it easy. So we're always comparing volume over time, or pressure over time, or flow over time, and just sort of taking it step by step and analyzing what is happening over time is a much better strategy, in my opinion, than just trying to memorize how everything should look or how it looks in every conceivable abnormal configuration. I would advise you to take a look at this book. I drew most of my material from this particular book here. This is called Rapid Interpretation of Ventilator Waveforms by these individuals here. I found this to be a very helpful, very logical presentation of all of these concepts. If you look it up, I'm sure you can find it helpful if you desire to dive deeper into learning more about how to rapidly interpret ventilator waveforms. So thanks again for joining me for this presentation. This is number 6 of 7. I'll see you in presentation number 7.